I'm going to talk about the long-term consequences of critical illness and try and make a case to explain to you all the problems that patients face after they leave the ICU. So they survive critical illness, but they leave the ICU with problems with cognitive impairment, functional impairment, and mental illness. And as Dr. Salis pointed out, we really want to make sure that our patients survive and then are back to the community where they are contributory and are useful, because that is what they wish when they survive. I have no disclosures relevant to this talk. So if you look at the landscape of admissions for critical illness in the United States, as an example, about 6 million patients are admitted to the ICU every year, and about 4 million patients survive their critical illness. So a lot of patients survive, and that is really good. What is important to realize that despite the aging of our population, patients are sicker, survival has improved. And so if you just consider survival over a period of time, and this study represents the survival change between 2000 and 2012. So not that long ago, but if you were admitted to the ICU in 2000 with either sepsis or non-sepsis in blue or red, the probability of survival is significantly higher in 2012, such that you have a 60% higher probability of survival now versus even a decade ago. But that may come at a price. If you flip this and see those patients who survive, are they going home? And what you realize that as compared to 2000, in 2012, there's a 4 times higher probability of you going to a place other than home when you survive your critical illness. You probably are going to a skilled nursing facility, maybe going to a nursing home, etc. So survival is increasing. The question is whether survivorship, the ability to go back to your family, go back to your interests, go back to your job, whether we are doing a good job with that. So if you look at big picture survivorship, the ability to go back to your quality of life, if our present scenario is such that you have patients who have full recovery, you have some patients who have significant morbidity after they survive, and then some patients who have death. If you're changing the death such that there's a reduced death, we have to make sure it's not at the risk of significant morbidity or at the risk of full recovery. What we want is we want patients with full recovery that is increased, a small proportion of patients perhaps with morbidity, and then the reduced death. So if your patients are surviving, you want them to survive with a high quality of life after they survive, so that they can be, again, contributory to their families, to the community, and to society in general. So this is one of the biggest challenges I think we have in this century, to try and ensure that patients are able to get back to their families, to their hobbies, and get back to work. Now, what are some of the problems that prevent patients to get back to enjoying that same quality of life? If you look at studies in sepsis and ARDS, they've shown us that about 30 to 50% of patients who survive a critical illness have cognitive impairment months to years after they have left the ICU. About 60 to 80% of patients have functional impairments, and that translates to disabilities. So you might have an impairment, but you may have reserve that you can compensate for your impairment. But then on the other hand, some patients are not able to compensate and have a disability. So about 30% of patients have disabilities because of the significant impairments that they might have. And about 10 to 30% have poor mental health, depression, PTSD related to their critical illness and the sequelae of their critical illness. Now, most of the studies that had looked at cognitive impairment after critical illness were small, 50 to 60 patients, and most of them were in a specific population, such as ARDS or sepsis. We wanted to look at cognitive impairment in a large cohort of patients who were in the ICU for respiratory failure or shock, so patients that we all see in our ICUs. So this was the brain ICU cohort, one of the largest cohorts looking at a prospective collection of data for cognitive impairment. So 820 patients with respiratory failure or shock. We had detailed in-hospital course where we evaluated factors that perhaps were risk factors for cognitive impairment during their critical illness. And then we followed these patients for months to years later. I'm showing you all the results of the 1-year cognitive impairment assessments. This cohort we have been following up, and we've just finished the 10-year assessments in this group. We started with 800 patients. Only about 200 patients are alive at 10 years who we have assessed for cognitive impairment, functional impairment, etc. But the 1-year data, if you look at this, our study had R bands as our cognitive impairment score. The normal score for R bands for patients is about 100 with a standard deviation of 15. So the green line is where the normal score is. Let's take two patient populations, greater than 65, less than 65. Let's think about our patients who are younger and are contributory in a significant manner for occupation, etc. So less than 65 years of age. Results are at 3 months and 12 months. And these box and whisker plots represent the scores in the R bands. The dark line over here is the median score of our patients. So this is less than 65 years of age at 12 months after critical illness. Median score was about 80, which is 1.5 standard deviations below the score of normal, which is 100. So a year after patients survive a critical illness, scores when we were assessing them on the R bands were 1.5 standard deviations below in 50% of our patients. In the lower quartile over here, so about 20 to 30% of our patients had scores in the range of what would be considered seen in mild Alzheimer's disease. So if you think of a patient population that did not have cognitive impairment, a year later, about 20% of them had scores in the same range as patients with mild Alzheimer's disease. And this is significant given the number of patients that we have that come through an ICU and survive. If about 20% of them are going to have scores similar to Alzheimer's disease at the end of 1 year, that's a significant problem. Looking at disabilities, as I mentioned, about 30% of patients had disabilities in their IADLs. And again, about 27% who had no prior disabilities had issues with disabilities in their ADLs. And so what is ADLs and IADLs, just so that everybody is on the same page? ADLs are simple things that we all expect our patients hopefully to do after they survive. Being able to bathe, dress themselves, eat themselves, bathroom, etc., being able to do that. If 30% of these patients are having problems with basic ADLs, that's a significant problem after they survive the illness. The instrumental activities of ADLs is a higher level where you have some cognitive function along with the functional pieces. So you're able to do your housework, able to take your medications. If 30% of our patients are having problems being able to take their medications after they survive a critical illness, and you all know how many medications our patients get discharged on, if they're having problems with that, that's a significant problem. Managing money, especially with all the financial scams that are going on nowadays, with the booming internet and people calling for money, if 30% of our survivors are having problems with managing finances, that's a significant burden on our patient survivors. Mental illness, depression is seen in about 10 to 30% of patients, and this is mild depression related to their survival, but it's important because those are somatic features and prevents people from doing things that they want to enjoy. And another stark feature is PTSD related to the ICU stay. So there have been many reports looking at PTSD, and it makes news articles saying PTSD rates are 30 and 40% after critical illness. But those are probably not full-blown PTSD, evaluating all the features based on the DSM criteria. So this is a study we did a number of years ago looking at PTSD anchored or based on ICU experience. And we assessed these patients months to years later and said, based on your ICU experience, do you have problems associated with these features which are common for PTSD. And what we found was that PTSD related to the ICU experience was seen in about 5% of patients. Now, you might think it's only 5%, but think about what rates of PTSD are there in the community. In the civilian population, rates of PTSD are about 2% based on other traumas in life, abuse, being mugged, shot, etc. Rates of PTSD are about 2%. Rates of PTSD in folks who come back or veterans who come back after active combat is about 10%. So rates of PTSD for ICU survivors is between what is seen in the normal population and what is seen in veterans or combat veterans who've come back from war, which is about 10%. So still a very significant issue, twice as much as seen in the normal population. What is more important is that the individual symptoms in PTSD are much higher. So intrusion is seen in 15%, avoidance behaviors, where you're trying to avoid anything that reminds you about the hospital, in about 40%. So imagine your patients who you have cared for, you've ensured that they have survived, and now they're scared to come back to your hospital for any follow-up visit because they're avoiding everything that reminds them of that hospital, which did a great job in making sure that they survived, but now they are uncomfortable because they're scared of coming back because of the PTSD or the avoidance behavior. And hyperarousal is seen in 40%, where if you suddenly come into the room, startle responses, etc., seen in a lot of patients after critical illness, related to examples or memories that they have in the ICU. Now, this cognitive impairment, functional impairment, mental illness does not happen in isolation. Number of patients have a combination of these symptoms, and these are all called post-intensive care syndrome, the combination of cognitive impairment, functional impairments, and mental illness. And it's seen in a significant, so if you think about how many are free of PICS, about 36% are free of post-intensive care syndrome. That means 64% of patients have some element of post-intensive care syndrome with an overlap, as you can see over here, between cognitive, physical, and then mental illness. So significant number of patients have all three, but often at least two of the symptoms that they have for months to years after they survive a critical illness. Now, the limits of post-intensive care syndrome is not just for the patients. Family members also suffer, and this is a terminology that the Society of Critical Care Medicine in their guidelines has mentioned, post-intensive care syndrome for the family, where patient family members are having psychological symptoms, problems with their quality of life, grief, and financial implications based on the fact that their loved one has had a critical illness and is now having problems associated with that. Now, I showed you all scores about the R bands saying that patients had scores 1.5 standard deviations below, and that about 20% of them had scores in the range of what patients would have with mild Alzheimer's disease. But that's scores. Does it have any real life implications? This is the same study, and what we evaluated in the brain ICU cohort was how many patients were fully employed at the time that they got admitted to the ICU when they felt sick. And we had 89% of our patients were fully employed at the time of ICU admission. And a year later, only 43% of patients were able to go to full-time job. 49% of patients were unemployed, with some patients going to part-time employment. So imagine if you have a patient population and the median age in this patient population was 55 years of age, if 90% of them were fully employed prior to their ICU admission, and only 43% are back to full-time employment, with 49% having problems with unemployment, it has a significant burden on society and a significant financial implications on the patient and their family members as well. So it's not just about low scores in any of the testing, but actual implications in patients' ability to care for themselves and for their families. Most of us at 55, if that's the median age, are expected to be working and providing for our families. And if we are unable to do that, it is going to be a significant burden on everyone. Now, what are some of the risk factors that are associated with these impairments that our patients are having? So older age, low levels of education, socioeconomic status are major risk factors for having long-term cognitive impairment. These are things that we can't change, unfortunately. We cannot change the patient's age coming into our ICU, can't change how much education they had prior to coming to the ICU. So these are non-modifiable risk factors. Frailty is a risk factor that we are hoping perhaps rehabilitation, where you're doing cognitive and physical rehabilitation, might prevent them from having problems, or rehabilitation. But sepsis, delirium, and perhaps the surgical and anesthetic procedures that go may be risk factors that we can modify. And I'm going to share some data about those with you all. So this is the first study looking at hospitalization and its association with cognitive impairment. This was done in the Seattle area. All these patients were enrolled in a particular health cooperative and were being assessed for cognitive impairment on 2 yearly basis. So these patients were 65 years of age and older. They did not have dementia, and they were being followed by this test called CASI, which is assessing cognitive impairment every 2 years. Now, in that patient population that was as part of this cooperative, some patients had an hospitalization and some patients did not have an hospitalization. And these authors compared the new onset dementia in the group that had an hospitalization versus those that did not have an hospitalization, accounting for all the other confounders. So if you look at this patient population, among the close to 3,000 patients, about 1,600 patients had no hospitalization, and about 1,200 patients had an hospitalization. Rates of new onset dementia, so incident dementia, 146 out of 1,600 versus 228 out of 120 of 1,287. If you consider the patients who had no hospitalization as your reference standard, so 1, the hazard of having new onset dementia was 1.5 times higher in the group that had an hospitalization as compared to the group that did not. Now, this does not mean that if you just show up in the hospital, you have worse dementia. The issue is what's something that brings you to the hospital, and things that happen to you in the hospital perhaps puts you at a higher risk for incident dementia. And those are areas that we may want to focus in. Another study, this is from the Rush Alzheimer's Center, and it's part of the Rush Memory and Aging project. They took patients who were 65 years of age and had no dementia. They followed these patients now for over 10 years. They've been doing cognitive testing in this patient population on a yearly basis, looking at a number of domains. And what they were trying to see was, well, hospitalization, I showed you, is associated with worse cognitive impairment. Is there any difference whether there is an acute emergent hospitalization versus an elective procedure that brings you into the hospital? Does that change the trajectory of your cognitive impairment? And what they showed was that over a period of time, and the y-axis over here is time, over a period of time, people's scores do change. And so as you age and time goes by, scores in global cognition reduce. But if you have an hospitalization, the score drops much faster than if you have no hospitalization. So again, a second cohort showing that a hospitalization changes the trajectory of your cognitive score much more than if you just had over time with no hospitalization. Now, what about this red line? If you split it for emergent hospitalizations versus elective hospitalization, what you see is the green line over here is elective hospitalization. That slope is exactly the same as if you had no hospitalization, but the emergent hospitalization is the slope that is much stronger. So if you were admitted to the hospital with an elective procedure, your probability of cognitive decline, the trajectory, is similar to what is seen in normal aging versus if you were admitted to the hospital with some process that required an emergent hospitalization, the trajectory is much lower and much sharper. Now, what could be some of those things that contribute to cognitive impairment? This is a study done by Jackie Vashina in Wisconsin, looking at sepsis as a potential risk factor for cognitive impairment. Again, these are health cooperative studies, so population-based studies. Patients are being followed on a yearly basis for cognitive impairment and looking at what happens in the interval period. Do patients get admitted to the hospital? Do they have sepsis? And if they had sepsis, what were their scores before they had sepsis? And what were their scores in the cognitive batteries months to years after they had their septic episode, using that septic episode as an anchor to try and determine whether the risk factors for cognitive impairment were based with sepsis. And what this study showed was that these patients were evaluated prior to sepsis, and about 5% of patients had moderate to severe cognitive impairment. Mild impairment was seen in about 7 to 8%. But after the episode of sepsis, the proportion of patients who had moderate to severe cognitive impairment almost went up 3 times as compared to what was in the mild range. And in multivariable regression, sepsis was associated with a 3.5 times higher odds of developing moderate to severe cognitive impairment compared to those who did not have sepsis. So again, hospitalization, emergent hospitalization, sepsis in that emergent hospitalization changes the risk for having cognitive impairment months to years later. What about surgery and the anesthetics that go? You cannot separate out risk factors of surgery and risk factors for anesthesia, but together, the sepsis and anesthesia put you at a higher risk for cognitive impairment as compared to non-sepsis, non-surgical admissions. In the brain ICU cohort, we found no difference whether you were a medical patient or a surgical patient with regards to cognitive impairment. So you can see the outcomes over here. This was surgical patients, median score at 1 year, at 3 months, and median score at 12 months, exactly the same, whether you were a surgical patient or non-surgical patient, showing that perhaps surgery and the anesthetics that you use are not independent risk factors for cognitive impairment. It's what brings you to the hospital, what happens to you in the hospital, perhaps that still puts you at a greater trajectory for the impairments. In the brain ICU cohort, we looked at delirium as a possible risk factor for cognitive impairment. And if you had 5 days of delirium, shown on this axis over here, versus 0 days, your score on the R bands was about 6 points lower, which is about half a standard deviation. So while there are many other risk factors for cognitive impairment, delirium perhaps contributes about a 6-point decrease in your R band score when evaluated a year later, if you had 5 days of delirium versus if you had 0 days of delirium. So going back to all the risk factors, we have a number of risk factors, but perhaps delirium is one of the potential modifiable risk factors for long-term cognitive impairment. So just to wrap it up in the last 2 or 3 minutes over here, what are some of the things that we can do to try and improve outcomes if you're focusing on delirium? There are a number of non-pharmacological protocols that have been studied in non-ICU patient population, but they seem like common sense approaches that we can look for even in our ICU patients. And as Dr. Solis pointed out, in the past, patients used to be often deeply sedated and comatose. We have moved a long ways away. Patients are interactive, are awake and alert often. So to help with reorientation in those patients, making sure that they have their glasses, their hearing aids, etc., to try and help with keeping them engaged is perhaps one thing that we can do. I'm going to talk about the ABCDF bundle tomorrow, but this is one approach that has been studied as part of the liberation and animation concept by the Society of Critical Care Medicine, focusing on assessing pain, doing daily awakening and breathing trials to reduce sedative exposure, reducing exposure to benzodiazepines and using non-benzodiazepine medications for sedation, monitoring for delirium, mobilizing our patients, and getting family involvement as a bundle that is shown to reduce delirium. So again, like ARDS, like renal failure, as an organ dysfunction, we don't have any magical bullet drug that can treat it, but the supportive care elements, best practices, are what is shown to be helpful to reduce delirium and perhaps, as we study that, cognitive impairment months to years later as well. This is a study that just came out, and it's an interesting study, small study, but this is by JP Kress's group from Chicago. And what they looked at was, does use of physical therapists and occupational therapists in the ICU improve outcomes with regards to cognition years later? So this group had shown that early mobility improves outcomes in the ICU. And that was a study done by Schweikart, who was JP Kress's mentee. And this is another study done by the same group showing that if you have occupational therapy and physical therapy in your ICU, they showed improved outcomes in cognitive status years later. So again, a proof of concept that the impact of mobility is not just for the ICU patients, but even later. There are a number of studies that are trying to look at other ways to try and improve physical and cognitive status after patients survive. So the early study by Schweikart showed that early physical therapy improves outcomes. The return study, small studies, proof of concept studies, showing that you can do physical and cognitive rehabilitation that's associated with small improvements in patient outcomes. The ACT ICU study tried to look at physical and cognitive rehabilitation starting from admission in the ICU. So proof of concept, and now a larger study is being planned to see whether we can improve outcomes if you continue this from a longer time. And we've just embarked on the COPE ICU study, where patients who are coming for elective surgery, we bring them for about 2 weeks before their surgery and give them cognitive therapy and physical therapy to try and improve outcomes after they survive their surgical procedure and they survive their critical illness, to try and see whether we can improve outcomes. So I'm going to end with saying that survivorship, the ability of our patients to be able to get back to the quality of life, get back to their community and become contributory members, is a real critical part and a real focus that we should all pay attention to, because we have done well to make sure the patients survive their critical illness. We have to do better to make sure that they are able to get back to the things that they would like to enjoy, their family, perhaps their job, as well as all their hobbies. Thank you.